This is a lecture on heart failure. Heart failure is defined as the heart's inability to pump sufficiently to meet metabolic needs of the body. That causes decreased tissue perfusion and as a result of decreased cardiac output. Cardiac output equals heart rate times stroke volume. Recall that stroke volume is influenced by preload, afterload, and contractility. Adverse changes in any of these factors causes a decrease in cardiac output and heart failure. Heart failure can be caused by excess volume load, meaning increased preload, or it can be caused by excess pressure load, meaning increased afterload. Conditions such as high blood pressure can cause this. Blood pressure is the product of cardiac output and systemic vascular resistance. So it follows that patients with high blood pressure may have an increase in cardiac output, an increase in systemic vascular resistance, or both. Heart failure can be caused by increased metabolic demand. For example, in a person with anemia, increased cardiac output occurs to meet the oxygen needs of the tissues. Heart failure can be caused by altered functioning, such as arrhythmias, leading to a decreased time. Filling disorders that can occur, or cardiac tamponade and pericarditis, both of those compress the heart, which impedes diastolic filling. Cardiac tamponade means that there's fluid or blood that has accumulated in the pericardium, the sac in which the heart is enclosed, and that's what places the pressure on the heart. With pericarditis, there's a chronic fibrous thickening of the wall of the pericardial sac that it causes the heart to be so contracted that normal diastolic filling doesn't occur. In taking a look at the pathoschematic for heart failure, we have a decrease in cardiac output, which leads to baroreceptors on the left ventricle, the aortic arch, and the carotid sinus being activated, which stimulates vasomotor regulatory centers in the medulla, which activates the sympathetic nervous system. So catecholamines such as epinephrine and norepinephrine are released, and as a result, there's increased heart rate and contractility. The sympathetic nervous system activation also causes vasoconstriction and therefore increases PVR, peripheral vascular resistance. Vasoconstriction, or PVR, causes an increase in afterload, blood pressure, and heart rate. With increased afterload, there's resistance to ventricular emptying. As a result, increased afterload causes more workload for the ventricle. So in terms of the blood pressure, think of a partially covering the end of a hose with your finger, and the pressure increases because the opening is now constricted or narrowed. And in terms of heart rate, constriction of blood vessels will increase heart rate, stroke volume, and therefore increases cardiac output. Another thing that's occurring because of decreased cardiac output is that you have less blood flow moving to the kidneys. So less blood flow means less oxygen getting to the kidney. In other words, you have decreased renal perfusion. Anytime the kidneys aren't perfused, an angiotensin-aldosterone system is then activated. And the reason it's activated is that you want to increase PVR, peripheral vascular resistance, and plasma volume. As a result, afterload and preload increases. With increased preload leading to the ventricle dilating or stretching due to the holding of more blood volume is what's happening. And although you have natriuretic peptides being used in effort to improve salt and water excretion, their effects are inadequate. Chronic ventricular dilation leads to lengthening of the ventricle wall and loss of effective contractility. So again, with increased afterload, there's resistance to ventricular emptying, and as a result, increased afterload causes more workload for the ventricle. Whether this increased afterload and resultant increased workload is the end of baroreceptors being stimulated or less perfusion of the kidneys, the ventricle responds to working hard by hypertrophying. So you have a thickening in the myocardium in this area. It's just like working out at the gym. You lift weights and your biceps, etc., get bigger and you can do more. But with the heart does not like that. It gets bigger and then it doesn't function well. A hypertrophy or thickened heart results in an increase in oxygen demand. Ventricular hypertrophy not only results from excess pressure, but it also results from excess fluid volume. Either way, the heart cells enlarge and they stiffen, and as a result, the force of contractions are decreased. The other problem is that the heart rate continuously increases in the attempt of trying to increase the cardiac output. Once it gets over 150 beats per minute, though, this actually decreases cardiac output. What's happening is that the heart is beating so fast it can't effectively pump out with each beat. So thereby, cardiac output decreases. And that ends up causing vasoconstriction, which increases afterload. The vicious cycle of decreasing contractility, in preload, and increasing afterload leads to a progressive worsening of the heart. So then you get left heart failure, also known as CHF. What this picture is showing you is left ventricular hypertrophy with and without dilation. And you have transverse sections of the heart. In the center, you have a normal heart to compare these with. The pressure overload of the heart, so look at the left side, has an increased mass, a thick wall, and a smaller lumen. And if you look on the right, you have a volume overloaded heart that has an increased mass, larger lumen, and enlarged size, or a normal wall thickness. Let's take a closer look at compensatory mechanisms. When the cardiac output decreases, the body will try to compensate, and it does several things to do that. It does this by increasing the blood that's returned to the heart, which will increase preload, and by stimulating the sympathetic nervous system, which causes vasoconstriction, which will increase afterload, heart rate, and contractility. Preload and load lead to ventricular remodeling. In other words, hypertrophy and dilation occurs to accommodate the high volume and pressure and to increase its contracting power. However, eventually the heart becomes too thick and gets stiff to contract effectively. So the same mechanisms that helped in the beginning now become detrimental. The pathoschematic for left versus right heart failure is as follows. Just quickly, the left forward failure causes a decreased flow of blood into the arterial system emerging from the heart, and that results in activity intolerance, fatigue, dizziness, and a decreased urinary output. Left backward failure causes pulmonary congestion, pulmonary edema, decreased oxygen, increased carbon dioxide, cyanosis, shortness of breath, cough with frothy sputum, orthopnea, and crackles. Okay, a discussion that's more in depth. When blood doesn't move forward, it accumulates or backs up in the left ventricle, and then in the left atrium, and eventually into the pulmonary circulation, in other words, the pulmonary vein. As a result, pulmonary congestion, increased pulmonary venous pressure, and pulmonary edema occur. With pulmonary congestion, that leads to impaired gas exchange. In other words, there's decreased oxygen and increased carbon dioxide. This leads to cyanosis, a blue color of the skin and mucous membranes. So a patient's lips and fingers may have a bluish or a purplish tinge. And it also leads to signs of hypoxia, such as shortness of breath. With congestion comes increased pulmonary capillary hydrostatic pressures and inflammation. That leads to protein-rich fluid being spilled out. Pulmonary edema results. So the patient will also likely cough up blood tinge, typically seen as pink frothy sputum, orthopnea, or shortness of breath when lying flat, and crackles. In terms of the right side of the heart, with right forward failure, you have an inability of the right ventricle to move blood forward and therefore into the pulmonary circulation and then into the left side of the heart, which ultimately causes a decrease in cardiac output. If blood isn't moved into the lungs, then it cannot pick up oxygen. In terms of right backward failure, also if blood isn't moved forward by the right ventricle, then it accumulates or it backs up into the right ventricle and then the right atrium, then into the systemic venous system. As a result, systemic venous congestion occurs that causes increased systemic venous pressure. So then you get peripheral edema. So you have dependent edema, ascites, the liver and the spleen become engorged, they become congested and enlarged. And as a result of this, you have hepatomegaly and splenomegaly. With this comes impaired liver functioning and impaired functioning of the spleen. The GI tract also becomes congested, leading to GI distress, anorexia, and weight loss. The accumulation of fluid is evidenced by weight gain. So in a patient with chronic right-sided heart failure, daily measurement of weight can be an indicator of how much fluid the patient has actually accumulated. As a result, or I should say as a rule, a weight gain of more than 2 pounds in 24 hours or 5 pounds in a week is considered a sign of worsening failure. With left ventricle failure, it's the most common cause of right ventricle failure. Sustained pulmonary hypertension can lead to right side failure. In terms of treatment of heart failure, in heart failure, there is decreased forward flow and increased backup of flow. The goals of therapies are thus to increase forward flow and decrease backup of flow. To increase forward flow, cardiac output must be increased. To decrease backup, the workload on the heart must be decreased. So with increasing forward flow by increasing cardiac output, you can accomplish that by one of two ways. You can increase the force of ventricular contraction by giving the patient inotropes, for example, digoxin, digitalis, dopamine, dobutamine, amrinone, or milrinone. Or you can decrease the rate of contraction to increase filling time by giving them beta blockers, sopranolol and metoprolol. The increase in filling time allows more blood to accumulate in the ventricles before contraction, leading to a subsequent increase in cardiac output. Decreasing backup by decreasing the heart's work. The heart's work is to pump the preload against the afterload. In heart failure, what do you think could be done to preload and afterload to make the heart's job easier? Well, you would give therapies that should decrease preload and decrease afterload. How do you think preload can be reduced? If you thought by dilating the person's veins, which will slow the return of blood from the veins to the heart, then you're correct. So you would give the person nitrates. Nitrates would do that. Also, you could use diuretics, which causes the patient to urinate more, reducing the intravascular volume. Success of diuretic therapy can be monitored by observing the decrease in signs and symptoms related to excess fluid, such as shortness of breath and edema. Arterial dilators decrease afterload, for example, ACE inhibitors or hydralazine. In discussing the kidneys a little bit more in heart failure, since cardiac output is weak in heart failure, the perfusion pressure in the kidneys decreases. The blood volume itself is not changed, but the pressure at which this volume reaches the kidney decreases. This is why we give a term or state a term called effective blood volume decrease. So effective volume depletion also can occur with cirrhosis. When the kidneys sense a decreased perfusion pressure, they try to increase this pressure by increasing blood volume. And talked about a way of doing that is through the renin-angiotensin-aldosterone system. So that system senses a decrease in renal perfusion and releases renin, which increases conversion of angiotensinogen to angiotensin 1. Angiotensin 1 is in turn converted to angiotensin 2 by ACE, angiotensin converting enzyme. Ang2 causes vasoconstriction, which raises the blood pressure. Angiotensin 2 also stimulates aldosterone released from the adrenal gland. So that leads to sodium resorption, the aldosterone being released, leads to sodium reabsorption by the kidneys, which causes water to follow it, which increases intravascular volume. The increased vasoconstriction and increased blood volume raises the blood pressure. Also, the perceived low volume status causes the release of ADH, antidiuretic hormone, from the posterior pituitary. ADH increases water reabsorption of kidneys and also contributes to an increase in volume and thus an increase in pressure. If the heart is already having trouble handling the existing blood volume, the kidneys and the ADH are not helping, right? You know, in a sense, you have this slow cardiac output, so the kidneys are thinking like, oh, we need to do something about it, and ends up adding to the person's blood volume. So the increased intravascular volume further aggravates the backup into the lungs and body that we've talked about. What you want to do is give the person ACE inhibitors, and that will decrease the conversion of angiotensin 1 to Ang2. Reducing angiotensin 2 production decreases both aldosterone release and Ang2 induced vasoconstriction, and then you won't get the increase in blood volume and blood pressure. So what you'd want to do is give an ARB, angiotensin 2 receptor blocker, to block the Ang2 receptor, and that'll lead to a similar effect. Aldosterone itself can be blocked at its receptor by aldosterone antagonists such as spironolactone. I included a slide on how you would prepare a patient that's hospitalized with heart failure for discharge. So please take a look at this slide. This concludes our lecture on heart failure. If having questions, please contact me via my email, halef@hawaii.edu.